Hi, everybody. Good afternoon. My name is Grace Whiting. I'm the president and CEO at the National Alliance for Caregiving. And gosh, I am just so thrilled. I've got my teacup. I'm ready to lunch and learn with all of you today as we talk about IBD and the care for that's provided to people living with IBD and working with family caregivers. So I'm hoping that what we can do as we settle in with our lunches, go around, just say hello to each other. And for those who might be listening, whether that's online or they're watching this recording, if you could just share your name, your organization, and why you're interested in how we care for each other, and particularly IBD caregiving. And I'm actually going to pass the baton first to my colleague, Chris, who's going to be helping me facilitate this discussion.
Hi, my name is Chris. I am with the Cincinnati Children's Anderson Center for Learning Network, Learning System Excellence. I primarily work with Improved Care Now and focus on patient and family engagement. I think one of the reasons I wanted to be on this call is to learn how we can better support care centers as they're trying to be more supportive to caregivers and patients.
So I'm looking at our Brady Bunch tiles. Brianna, would you like to go next?
Sure. Hi, my name's Brianna. I'm the IBD coordinator at Phoenix Children's Hospital. I'm also a Crohn's patient, and my sister has some autoimmune illnesses as well, so I'm kind of a patient and a caregiver and a nurse. So I feel like I have kind of a wide range of perspectives on the issue, and I'm just interested to learn more and see how I can not only be a better caregiver, but a better provider of care in the clinic.
Awesome. Elisa, would you like to introduce yourself to the group?
Sure, thank you. Elisa Bovey, I'm an occupational therapist. I've worked in long-term care for a number of years. Also a Crohn's patient, recently had a total colectomy, trying to recover from that. Cared for a family member who had an ileostomy. And I have found so many more patients and residents are being diagnosed with IBD, but caretakers don't have that intense training and background like in the acute hospitals. So I feel really passionate, and I do a lot of training, but I would love to be part of, able to expand that and broaden it across the country.
It's wonderful. And Varlisha.
I am Varlisha Gibbs. I'm the Vice President at the American Occupational Therapy Association for Practice Engagement and Capacity Building. I am an occupational therapist by trade. In my former life, I had a practice where I worked with a lot of individuals and families with conditions, neurological conditions, and autism. So I'm very familiar with the diagnosis of IBD, as well as working as a researcher in the field. And personally having connections to not directly IBD, but being at risk, having celiac, as well as having a parent who had colon cancer. So it's definitely something that's close to heart. Thank you.
Thank you. Jen Pettis.
So I'm Jen Pettis. I'm the acting director for programs at Niche. And the reason I'm on this call is Charlotte was kind enough to share some resources with me and said, hey, we're also doing this call. We'd love a nurse's perspective. And I immediately thought of Elisa as giving an even more important perspective. But we do a lot of, in addition to training nurses in care of older adults, we do provide family resources as well on our public-facing website. So I'm certainly interested to learn more from you guys.
Jennifer.
I'm Jennifer, a research coordinator at New York Presbyterian Weill Cornell. And basically I'm on the call too to learn more from all of you guys. My brother was diagnosed with IBD at a young age, and I've been a coordinator at NYP for a while, doing a lot of research with IBD patients specifically. And so we would love to learn better ways that we can support all of our patients and parents.
That's great. And Jamie.
Well, like Jennifer, I am a research coordinator in the gastroenterology department. I'm involved in the Quality Improvement Network, Improve Care Now. I wanted to join, and I'm always interested in learning new ways and trying to help our patients. And so I wanted to join and see if I can help any way, as well as learn other ways.
That's awesome. And then I'm looking at my colleague, Patrice. I don't know if you want to say hi to the group.
Hi, I'm Pat Hines. I'm the Vice President for Strategy and Operations at the National Alliance for Caregiving. And the IBD survey initially, when it came in the door, was a project of mine. And as it evolved over time, we moved it into Charlotte and Gabriella, our research directors, willing hands.
Okay. So I'm going to pass things to Charlotte. Charlotte's going to talk us through a couple new resources, and then we'll move and back into our Hollywood squares for discussion. So, feel free, while Charlotte's walking us through this, you're welcome to turn off your video, and then we'll come back to discussion after Charlotte's done with myself and Chris.
Awesome. Thanks, Grace. So before we open up the discussion, I just wanted to give everyone a brief overview of our recent research and resources on IBD caregiving. So back in 2019, which feels like a really long time ago, the National Alliance for Caregiving, the Crohn's and Colitis Foundation, and Improve Care Now worked together to develop the first of its kind national study on IBD caregiving. So what we found was that caregivers are a key member of the IBD care team. So they're spending about 20 hours a week communicating with medical staff, insurance companies, and schools. They're also managing medications as well as finances and preparing specialty meals. One common thread in this study that is also found in other caregiving settings is that caregivers are stressed. Over half are experiencing emotional stress, and 16% report experiencing depression from providing care. 6 in 10 also reported struggling with a sense of loss over what the care recipient's life would have been like without IBD. So these findings helped us develop some follow-up materials geared directly towards caregivers as well as clinicians. We addressed the gaps between what caregivers are trying to accomplish for their care recipients in reality. So our guide for providers addresses the need for ease of access to evidence-based information and resources for caregivers, the need for clinicians to help facilitate shared and supported decision-making with the caregiver, patient, and the entire care team, and the need for medical professionals to consider how to better provide training to IBD caregivers, particularly for medically complex tasks. And finally, the need to support and protect caregivers' well-being. So our flyer for caregivers also addresses some of these need gaps by providing caregivers with helpful resources and information. But the first piece I'd like to discuss is what's most relevant to today's discussion, which is the Provider's Guidebook. So in this guidebook, you'll find tips on how to work with IBD caregivers to ensure that they're engaged and empowered to participate in shared and supportive decision-making processes, that they're also equipped to provide the best care to their care recipient, and that they have access to the necessary support and resources to protect their own well-being while navigating their IBD care journey. During our interviews with IBD caregivers and patient advocates that were conducted to direct this work, we learned about what they would have liked their care recipient's physician to do differently to support them and the patient. And most often, we heard that they would have liked or that they appreciated being engaged in shared and supported decision-making. Because IBD is a condition in which finding the right treatment and diagnosis can take a long time and can be very straining for both the patient and caregiver, it's vital that they're both involved in decision-making when it comes to treatment decisions. So recommendations to involve the caregiver and patient in this process are included in the guidebook. And we hope that providers will be able to take away this information in order to better communicate and engage with both IBD patients and their caregivers. So here you'll see an excerpt of one of the pages from the guidebook. And you'll see at the top, we show the study finding, its significance to providers, and finally, some recommendations on how they can address that challenge. The guidebook has 4 strategies for providers to engage and support caregivers, and you can access it for free on our website at caregiving.org/IBD. So the second piece of this follow-up work is the Caregiver Flyer. I'd just like to briefly introduce it to you all. So our 2019 report outlines several need gaps facing IBD caregivers, many related to a lack of resources and tools to support their care recipient living with IBD, as well as themselves. Many of our interviewees for this follow-up work pointed out some critical challenges facing IBD caregivers that add some more nuance to our report findings. And they painted a picture of how providers may not always address caregivers' concerns if they're derived from non-evidence-based internet resources. So it's really critical that IBD patients and caregivers have access to reliable resources in order to validate their concerns at the doctor's office and equip them to participate in shared decision-making. So here is the flyer, which can also be accessed at caregiving.org/IBD. And it contains resources for caregivers, as I mentioned, as well as some statistics to help them, connect with other caregivers and resources to support them on their IBD care journey. So feel free to view and share both the guidebook and flyer, which are both available on our website, again, at caregiving.org/IBD. And if you're currently working in a clinic that you think would benefit from a hard copy of these resources, feel free to reach out to me at charlotte@caregiving.org, and we may be able to arrange some hard copies to be sent to your clinic. So with that, I'm going to pass the baton to Grace and Chris Keck from Improve Care Now, who will be helping to facilitate today's discussion.
Thank you, Charlotte. I really appreciate that. And Chris, I'm wondering from the outset if there's anything that comes to mind that you want to talk about. A couple of things that I know Charlotte and I were thinking about, just how are people working with families? But I also know that COVID-19 has sort of thrown everything for a loop. And so I'm going to ask you if you have any immediate reactions, but also questions that you might have for our distinguished Lunch and Learn participants.
Yeah, I think that there are a couple of things that we've tried to learn over the past few years as we've been trying to build the infrastructure to support patient and family engagement at the local level, or help care centers to build that infrastructure. And one of the challenges that we've seen in the past few months has been making that initial connection and getting resources to patients and families. And so I guess one of my first questions would be, how has the relationship for, I think, the folks who are in clinics, how you communicate with patients and caregivers, has that changed over the past few months? Have you been able to incorporate it into telehealth? And what kind of impact has that had on you know, do you feel like you're able to be as supportive as you have been in the past? Or are there things that you feel like are missing? I guess that's the first thing that jumps to mind. You know, what were you able to do before? Are you still able to do it now? And if not, what are the pieces that have been difficult?
Yes, I would say we're kind of in that process and trying to learn. We previously, before COVID, it was a lot easier to get those resources to the parents and the patients in clinic and the infusion center. And just with these past few months, we've been kind of trialing emailing all of our patients and parents the links to go to websites and, you know, to get those resources. So it's definitely been a change. And then just in addition, there hasn't been as many families and patients coming into clinic. And then even with the new clinic protocol, there's not even as much time to have those discussions, because usually they send them right in to see the physician and then they're getting labs and leaving. So it's it's been a little difficult just in that method. So we're trying to just use as much as possible email communication, and we haven't done as much phone, but I would assume that would also be, you know, helpful just moving forward.
What about others? Have others, you know, how was it working with families of your IBD patients before COVID, and what's changed?
So I actually just started my new role as the nurse coordinator for the IBD clinic right when COVID started. I think I had like half a day of in-person orientation, and then I went to all remote. And so something that's been challenging is establishing relationships and connections with the parents and with their kids. And that's something that I'm really missing from being an inpatient nurse. But it's been challenging to give information. Sorry, there's a garbage truck. Because I feel like everybody has technology fatigue right now. And so I'll provide a lot of information, phone call and email, but I don't feel like it's being very well received. Because everyone's just kind of tired of staring at their phone. So that's definitely been a challenge.
I think that's a great point. That's sort of Zoom fatigue, I've heard it called. You know, Chris, as we're thinking and talking with our colleagues here, one of the questions that I have is, what about people who are in the home and who are having to sanitize their home, and the challenges of even, I was thinking about even having to share a bathroom. You know, if someone might be at risk for COVID-19 and they're also trying to balance this autoimmune disorder, which may require the use of, you know, those spaces. I'm wondering if folks have run into those kinds of issues.
I want to give other folks a chance to reply. I should say, I haven't had a specific conversation about that in a couple of months. I'm part of a cross learning network patient and family engagement group called the Anderson Center Engagement Collaborative. And I think it must have been May, we had a conversation with parents from a number of the different learning networks. And one of the things that I found most interesting was that a lot of them actually, this is going to sound odd, and I don't mean it exclusively. The pieces of feedback they gave is that in some ways this has made their lives easier. And what I mean by that is that the general public, they've had to do those things for a very long time. And kind of the infrastructure and expectation of the general public is now that they do the same things. And so it is easier for them to navigate the world because the world is more set up for them to be able to do that stuff. They actually, like, specifically speaking about telehealth, one of the things they shared was like, hey, we've been fighting for this for a long time and we're happy it's here now and we hope it never goes away. I found that very interesting, right? Like, I went into that conversation expecting to hear them all express their fears and express how things have been more difficult. And I know it sounds odd, but a lot of them shared the opposite, right? Not that they enjoy how things are now or that it's perfect, but that the rest of the world is experiencing a little bit what they go through all the time, and it's made it, you know, a little more convenient. I'd be interested to hear from folks. Have you heard any of those questions coming from patients, families, anybody you talk to, or have they expressed like challenges in being able to implement, you know, some of the things that you're recommending that they do?
Well, and I'd love to tug on, yeah, my the therapists and the nurses. So Varlisha, if you, yeah.
Yeah, I can hop in, but this is not going to be from the clinical perspective because obviously I'm working in the office, the virtual office these days. But you know, just speaking to the comment that Chris made in regards to telehealth, we certainly here at AOTA have found that that has been one of the positive, if you could look at it that way, outcomes of all of this, right? That we're able to have our clients and families serviced in ways that we have been advocating for a long time. So that we hope that these things become permanent as we move forward to be able to support, especially our caregivers. And coming from the side of a caregiver that had to deal with extreme outcomes of illness, for me, it would have been great to have the option for telehealth. And then also, I see what Chris is saying. It does sound odd, but it is a walk in the shoes of individuals that have to deal with isolation when you're dealing with these illnesses, right? Having to have social isolation, but also even just the physical of having to be near the restroom, right? And so how that impacts your health, your well-being, mental health, your family makeup. And so it is a little bit of a taste of that to perhaps maybe expand that understanding, right, of what families have to go through. So I do get what you're saying there, Chris.
Absolutely. I wonder, it's such an interesting perspective. I'd love to know, some of our nurses, are you feeling the same way about telehealth, or is it something that's adding more complexity on your side? Because I imagine that trying to manage that in the pandemic and day-to-day care is really challenging.
So I'm not a nurse, I'm an OT, but I have a few thoughts that I would love to share. So I'm on the other end of the spectrum, not the children or pediatric side, but the geriatric side. And I have found a couple of things. One is to train family members, because we can't have family members in visiting in long-term care, is extremely difficult through video. You know, if you're training on something that's a new device, it just doesn't happen. So that can delay somebody's recovery and ability to go home. You know, and as you were saying, it is nice to be in your own environment and have steps away from, you know, the bathroom and, you know, if you're the patient themselves. And so the success of the patient to be able to transition home with their caretaker certainly is a struggle right now, because video training really doesn't work from that perspective. And the one other perspective is the support group piece and Zoom support groups. And I guess it depends on what you're struggling with, because I've heard people who are on the addiction side, it's a different conversation, but they like the phone, they like kind of the anonymous piece. But to be on the phone, it's just not interactive enough if you're a caretaker and you're participating in support. And oftentimes people don't turn their video on, and the technology piece, I mean, I'm in that older generation where we had the dial-up and never even had internet. So sometimes technology is not your friend. So that has been definitely a challenge, is to feel a connection. You know, when you're sitting in a room of some, you know, a site, sometimes you use a church, sometimes you use a school, whatever, certainly more personal. And I feel like people share more and you get more solutions and you have more kind of quality, you know, interactions that you walk away, you know, feeling like, oh, that was a good session. I feel like I can now approach my mom or, you know, whoever it is with some strategy.
Thank you for sharing that. You know, one thing I'm wondering, and I know this is lunch and learn and not happy hour, but I've been wondering, because we debate this in terms, where are family members being helpful and where are they maybe not being as helpful, and how do you address that? And I'm wondering if Jen or Jennifer or Brianna or Jamie, if you guys have any thoughts on that.
It's Jen. I would just say that's as individualized as the patients themselves, right? As I'm an old nursing home nurse who said, oh, thank goodness their daughter's coming today, so-and-so will feel better. And then the next one said, oh my goodness, oh no, their daughter's coming today, let me go take a break. I think it depends. But I think there's such an important role, and Lisa mentioned the discharge. I mean, I think for older adults in particular, the multiple providers that are so well documented that each older adult has is such a unique challenge, with medications and discharge planning and ensuring the follow-up. And now we're looking at getting folks to follow-up appointments, but what if they depend on public transportation or cabs? Now they're scared to do that. So it is such a whole new unique set of challenges.
Can I ask a follow-up to that? Because it like, when you mentioned the transportation challenges, before I did this work, I worked for a healthcare nonprofit, and a lot of what we did was help folks connect to enrollment assistance so that they could enroll in Medicaid, and got to know a lot of the managed care plan folks through that work. And I know one of the things they offered was transportation. Have any of you heard, have any of you found a difference in challenges for caregivers based on socioeconomic status or health insurance status, right? Like, are certain things more difficult for folks who have Medicaid versus private insurance? And what are those things? And then are there any, and the answer may be no, you may not have noticed differences, but when you mentioned transportation, that's one thing that jumped out. I'll ask a very direct question to maybe narrow it down. Do you find are there more technological challenges with any group of people? I'm talking access to internet, access to the devices needed to have telehealth visits, access to transportation and those things.
So it's Jen. I'll answer that from kind of a different spin, in that my sister is a teacher in upstate rural New York, and she's busily preparing internet lessons for usually 1 or 2 kids to watch them. Another one of my best girlfriends right around the corner is a teacher in Schenectady, New York. She teaches special ed. One of the moms, single mom, very low income, with a special needs kid, gets a hold of her finally and says, I actually can't read any of the texts you've been sending me.
Okay.
So again, I don't want to equate children to, but these are kids who grew up in the technology era. So now take all of those socioeconomic issues and now put them with a 70 or 80-year-old. And I can only imagine, how bad it is. I mean, and just there's such a fear of being taken advantage of by so many older folks. So do you trust that person who may be, 30, well-dressed, good-looking young guy on the other side of the phone is really a doctor? And do you really give them all of your health information? And again, this is, the world according to Jen. This is not research. But I just think about the world in general and how we are, some things are working so well and some things are working so bad for a lot of people.
I see Jennifer and Elisa are also unmuted. Did y'all have thoughts on the same question?
This is Jennifer. I was just going to kind of follow up with that just in terms of the social economic status for our patients. So yeah, we've seen a bit of a difference. We have two separate clinics, actually, one for just our Medicaid patients, and it's been really difficult to keep a consistent follow-up with the providers. So they'll be scheduled for the virtual visits and then they just won't show up, or they'll be confirmed and they won't log on, and the provider will have to call them and they kind of have to work through it in the moment of trying to get the access. And we haven't really seen that at all with our other clinics. There hasn't been any issues with them logging in on time or having trouble making accessing the site to do so. So I feel like we've seen differences there, and I think it's actually pushed forward to a lot of our leadership, where now they're discussing not separating the clinics anymore and having a one clinic for everyone. And that, I guess, also has to do with it's not only for the GI specialties, so there's a lot of other specialties that use the Medicaid clinic on different days. So I think that's kind of a larger talk that they're kind of discussing moving forward, what a better plan would be.
One of the things I picked up on is that in some cases it sounds like the docs are actually like doing tech support. It's been my impression that physicians, there's a wide range of how comfortable physicians are with technology right now. Has that been a challenge for, like, have any of them talked about that that's a challenge for them? Yeah,
so I think they hadn't talked so much about it. Well, they've talked about a couple instances where they'll try back and forth to connect with the patient, and then after a couple of runs, if it doesn't work, there's been a few instances where they'll just call them and just like document it's just going to be a phone visit.
Okay, that's helpful. Thank you.
Yeah. Other thoughts or reactions?
Would you like just a general reaction to the material? Yeah. So I'll tell you a little story and then I'll give you my reaction. Last year I was at the Wound, Ostomy, and Continence Nurse conference down in Nashville, and I was listening to one of the speakers who was speaking on it's called the explicit. It's a expanded plicit, which the plicit is all about speaking with folks about sexuality and assessing their sexual health. And she told, one of the participants got up and said at the program that she was a relatively new colostomy patient in her 50s. She was at a support group or some kind of ostomy patient in her 50s, and she was at a support group, and she said to the support group something about, could you give me some tips on intimacy with my husband? And one of the gals at the support group said, just forget about that, it's over. So I was happy to see in your material to talk about intimacy, but I think that that's something that health professionals do really badly. I'll give you a personal example. My husband is an amputee, or relatively new below the knee amputee, and we've had exceptional care. No one ever mentioned anything about intimacy and how that enormous life change would impact that. So I think that that is something that really needs to be addressed and spoken to, and really actionable items be given to healthcare professionals, because they don't even, unless you're an expert in ostomy care and you know about different belts and all of these different things, you simply don't even know where to begin to what to tell folks.
I think that's really helpful, because I know when you're caring for someone who may be your partner or your spouse, it adds just additional stress and strain that people aren't always aware of. And I'm looking at our occupational therapist through the Zoom and others, and wondering what your thoughts are on, how do we get at these sort of holistic life concerns? One of the things that we did in this guidebook is we provided, some example billing codes of where clinical providers could get reimbursed for family support services. But I think part of what I'm hearing is it's not just the physician can't handle everything. So what about this interdisciplinary care team? Where can other people be helpful in sort of helping the family manage the disease?
I think that it needs to be part of your goals and certainly part of your focus. But what I have seen, and again, not from the younger population, but nobody really wants to own it. And it sounds a little disturbing, but the nurses, there are ostomy nurses. And so they're amazing in the acute setting. Like they give you so many supplies and they give you all the things that you need. And they'll have nutrition conversations and this and that. But you talk about transportation. Well, how long can we be in the car? How long of a ride can we take? Can we go overnight to a hotel? What happens if, and especially in COVID world, you can't just run to CVS. They're not 24 hours anymore most times. So where do I get my supplies? So there certainly is many, many conversations, and having some type of like a recommended questions or topics, to discuss with patients would be extremely beneficial. And I think, intimacy 100%, Jen, I agree that people, even though we're therapists and you see everything and you hear many things, people still don't feel comfortable. And I've sat with a group of OTs with a facility where they had a neurostomy patient. We talked about goals and, what kinds of things do you talk about and what do you think? And people just shy away because there's not that familiarity. Although now there's so much more frequency of patients with those diagnoses, I think that it will be, it will behoove to have the materials as you do and to continue to encourage people to incorporate set up a specific treatment session. This is going to be, a social interaction when you're in the community, what to expect at home. You can certainly talk about intimacy. How do you explain what happened to relatives? Like nobody wants to talk about poop, right? Like it's embarrassing and you feel like, I know, right? Many of us on this call have experienced it. And you have certain friends that you're like, yeah, I can tell you, but you get nervous. And what happens when you get nervous? Just go nuts, right? So there's all these different emotions involved. And so I think we absolutely need to do an emotion check and really keep people feeling like there are more options than simply, well, you're going to be home for the next 6 weeks. You might be with COVID, but, once things start to open up a little bit more, what can you do? How do you approach that? So.
Brianna, I see your head nodding. We'd love to hear from you on what you're thinking.
Yeah, so that's something that's actually been a challenge for me as of late because I'm trying to create a transition program for our pediatric population. And something that's been difficult is approaching the issue of sexuality in IBD for our young adults, as we tend to keep our kids from 18 to college now. We're keeping them much later. And that's something that the docs don't want to own. And as an organization, we really kind of skirt around. But I know that it's not even just the discussion of, okay, kids and relations, it's identifying as a woman with Crohn's. I think that that's a huge piece in their development that we kind of stink at talking about, but it's been really difficult to navigate how to approach it in the most politically correct way because the parents are still very involved.
Varlisha, did you want to chime in as well?
Every time someone speaks, I have like a light bulb go off, so I'll try. It's a lot there. Gosh, thank you for that last comment. When I think as looking at things from the lens of an occupational therapist, and you spoke a little bit about, interdisciplinary, and when I think about interprofessional collaboration, it's very important for one, to have referrals, right? So occupational therapists tend to be floating out there as qualified members of the team that may not always be tapped into, right? And it's like, we could have like a secret sauce for one of these topics, but no one's, realizing that piece of it. So it's up to the practitioner to, of course, advocate for that, right? To be able to share that, which we're kind of doing now, but also to be sought out, in terms of those referrals to do a more holistic approach to care. And especially as we're talking about, there's a couple of things there. There's sexuality, but there's also gender identity and how they intersect, right? So the sectionality of those things. So when you think about that, I think one way to tackle it is to have more discussions, to have more trainings, and they should come from the view of different professionals. So, doing webinars that have an interprofessional team that can present from their perspective and what role that they would play within resources. Case scenarios, right, would be great in terms of having a case. And then how does the nurse play a role in this? And it could be based on sexuality, right? And how does the occupational therapist play a role in this? And so when you start to build those bridges and have different ideas coming from, the way I think as an OT, the way someone may think as, a different practitioner or a nurse or a doctor, that's when you start to kind of fill in these gaps. And, as we stated, no one wants to own it, but I think all of us need to own it. And that's the way we really start to make progress in terms of some of these topics.
So I'm wondering, let's say I'm a mom and my baby girl is a senior in high school, okay? And the first thing for I have changed my career to be able to care for her. I've made pretty, extensive decisions in my own life so that I could care for her. And it's hard for me to see baby girl growing up. So what advice would you give to me as the parent on managing some of these transitions? And what advice would you give to the physician who might have to field that initial conversation?
I can just share kind of personally, since I grew up with IBD, I've kind of seen two kinds of parents. I've seen the really, the helicopter parents, if you will, and then I've seen the way too laid back parents, and then I've seen the just right. And thankfully my mom was just right, and she trusted me, and as I got older, she kind of let me take the reins little by little. So she kind of had her own transition program, I guess, to where when I was 18, I was the one going to the appointments, and then I was the one talking to my physician rather than my mom talking for me, and I'm just sitting very quietly and nodding my head. So you kind of have to feel it out, because I think every kiddo is different and what they're comfortable with, but also encouraging them to, to use their voice and speak up, especially when we're talking about things like IBD that won't go away. Eventually they're going to need to own their disease, and helping them gain that independence is huge, and it's going to set them up for a really strong foundation for the rest of their life.
Hi. Oh, sorry. That's actually a great comment. This is Jennifer. We're kind of doing the same thing at our center too, trying to start earlier on with our patients when they're around 14 years old and introduce our transition program to them. And they fill out a series of assessments over time where it'll ask them, do you know what your medications are? Do you know what your dose is? Do you know who your doctor is? And try to get them to have that independence. And kind of sort of build it up so that eventually when they are ready to transition, usually our patients also stay with us for a while through college, but once they are ready to, they're more confident that they have those tools.
And I think on that second piece, what about physicians? I have to smile because, as all of us are patients in addition to working in this field profession. And, you have very different experiences. Some physicians have great bedside manner. Some,
are skilled in other ways. So what advice would you give to people who are practicing day to day, who say, I don't know what to do with this family member? Or, earlier, I think Jen had said, oh no, so-and-so's sister's coming down the hallway, it's time for my break. What advice do you give to the provider who's trying to tackle that?
So I'll share a little on that. I think the provider needs to set the stage that he or she is not the fixer of all things, that the interdisciplinary team is empowered to fix stuff. Again, I speak from experience with, I had a wonderful medical director that I worked with for years at the same nursing home, and we were blessed. He was there full-time, 5 days a week. But when people went to him, he would always say, let's go talk to Jen. She's in charge here, and we'll talk about it together. And so I think the worst thing the physician can do is undermine the actions of the rest of the team by being the one that the family sees as the one person who can really fix stuff. That will ultimately come back to bite him or her, but it also leaves the team struggling to find relevance for that family or patient.
I think we have about 5 minutes left. I'd like to wrap up with one question and actually build off of. I want to build off of that because interdisciplinary team was mentioned. So one of the things that I've heard, maybe not explicitly in these words, but is that it's been more difficult to involve a multidisciplinary team in care, especially now, for lots of reasons. It's harder to get multiple people on telehealth visits. There are furloughs going on at a lot of health facilities. How has your work with an interdisciplinary team been affected over the past few months, and has it changed how you support caregivers? Anybody feel free to jump in, even if the answer is like it really hasn't, or we haven't figured that out yet. I think that's helpful for folks to know and be able to relate to. No?
I'll say for the long-term care industry, it's actually been the interdisciplinary team is that's all you get. Like, you don't get the caretakers, and initially physicians were not coming. So we would have to try to involve physicians through, phone calls, or if they had the technology. But from social service to all the therapies to nursing, it's been kind of great because that's all you have. You're busy. You're super busy, especially if you have COVID units. But we've had a distinct advantage, I know, except for caretakers, and as I mentioned before, the family members aren't able to come in, but our interdisciplinary teams have really been able to have some good continued quality conversations.
Can I ask something? I want to ask something specifically to the folks in Phoenix. You all had a pretty active parent group there, parent caregiver group, like before COVID. I haven't talked to them since then. Brianna, I know you're new. You may not know. Jamie, I think we may have talked about this before. We've at least emailed. We've had a couple of folks, I think they were grandparents, come to community conferences. Have they been able to stay active and keep kind of on their normal routine, or have they had to pause things? Or you may also not know. I acknowledge I'm putting you on the spot a little bit. Mary Lou, I think, was one of the ladies' names. That may be wrong.
Yeah, so we still have meetings, but a lot of the events that the parent working group was planning has been largely put on hold. the big discussion has been, well, do we do something virtual for caregivers and for kiddos, or do we wait until this kind of blows over? And it doesn't look like it's going anywhere, so that doesn't work now. But they're still very much trying to be active, but they're having a hard time really offering the same level of community support that they had in the past.
Okay. If it's helpful, and feel free to email me offline, I'll put my email in the chat. The folks at Vermont and at the twin Atlanta centers, I know have both done virtual events in the past month or so. It's funny, I said that, and Ian from Vermont just emailed me. It like just popped up on my computer. But if you talk to them and they're interested in connecting with a parent group that has done virtual things, let me know and we can make a connection. That's helpful. Thank you. I think that's,
Thank you.
I think that's all I have. Again, I put my email in the chat. There were a couple of times when I put our website there. All of our resources are available on improvecarenow.org, including toolkits that are developed in coordination between patients, caregivers, physicians, and nurses, like the whole multidisciplinary team is involved in creating some of our toolkits. And so if there's anything that, any specific thing that you can't find on there, feel free to reach out and email me. Otherwise, wanted to make sure you all had access to those things. Grace, Charlotte, do you want to?
Yeah, I just want to say thank you guys for the open and candid conversation. I mean, really, really great insight, particularly about thinking about these areas that people may be unprepared or even not comfortable yet talking about with families, things within care transitions related to human sexuality, related to gender identity, and other pieces of who you are as a person living with IBD. Particularly the advice to providers to remember that we're part of an interdisciplinary team, that the family member, as well as nurses and therapists and others, are all have roles to play in help supporting people. And just the conversations about the work that you're doing in each of your respective organizations around family members, around supporting caregivers and people living with IBD. I also thought the perspectives from geriatric to pediatric were fascinating. So, you know, it really is an honor to have lunch with all of you, albeit virtually. And I would just encourage you, as your work develops, please continue to rely on ICN. Please know that you can use our resources and connect with Charlotte about the IBD caregiving resources, but we're always open to hear what you're thinking about, what you're working on.